We can start the first presentation in the second session with Dr. Amr Al-Najar, our college in the Sabah University. He is interested in the female urology and urodynamic study, one of the pioneers in this file. You can start, Dr. Amr.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه الطيبين الطاهرين. Thank you, Dr. Nabil, Dr. Abdul Rahim. I would like to share my thoughts with you about the overactive bladder. Now, when we talk about overactive bladder syndrome, we usually don't like to deal with these patients. We don't do surgeries. These patients will come and return. But we need to remember that whenever you see a patient with overactive syndrome, هو هذا عفوا يشتغل لا شباب ما رضيش خلاص. When we talk about overactive bladder syndrome, it's really this is one of the pictures that really reflects this entity or this syndrome. And it's mainly crossing the or putting your hands over the lower abdomen. This is mainly what most of the patients present like. Now, the terminology according to the ICS, the latest one, updated in 2019, it's urinary urgency with or without urinary incontinence, often accompanied by frequency. Typically, we refer to 9 voids or 9 micturations per 24 hours, as well as nocturia defined as more than 1 micturation interrupting our sleep. In the absence, this is very important, that urinary tract infection or any other obvious pathology. Now, in my presentation, I will try to make it concise, and I will talk mainly about the treatment. The first line treatment, we divide it into 4 lines of treatment. The first line of treatment is the behavioral therapy. Second line of treatment is the pharmacological therapies. Third line treatment, the minimal invasive procedures, mainly talking about the peripheral or posterior tibial nerve stimulation, as well as sacral neuromodulation. And finally is the, as our last reserve, augmentation, cystoplasty, and urinary diversion. Now, behavioral therapy, we talk about mainly bladder training, asking the patients to control, to try to delay the voids as much as possible, mainly using the voiding diaries. It's the same for bladder control strategies, pelvic floor muscle training, as well as fluid management. And in the European Association of Urology guidelines on the female, on the management of non-neurological female lower urinary tract symptoms, recommendations were that a reduction of caffeine intake may reduce symptoms of frequency and urgency, but it may. Reduction in fluid intake by 25% may help improve symptoms of overactive bladder, but not necessarily the urgent urinary incontinence. And this is mainly important in our society because most of our patients, they present with a history of frequency, but when you take a detailed history, you will notice that they are drinking 3 liters, 4 liters, 2.5 liters over in the afternoon while cat chewing. Obesity is a risk factor for urinary incontinence, mainly in women, but the relationship to other overactive symptoms remains unclear. Now, when we talk about the pharmacological therapies or treatments, 4 types of, or 4 groups of drugs: the anti-cholinergics or the anti-muscarinics, the beta agonists, the antidepressants, and some may include the botulinum toxin A as a pharmacological treatment. Some will include it in the surgical treatment. Now, if we look, this is one of the tables. Now, this is one of the tables presenting a number of anticholinergics. We start with the old one, which is the oxybutynin, either the immediate release or the extended release, oxybutynin gel batch. And all of these they work by blocking the M1 to M4 receptors. And if we compare them with other drugs, the main disadvantage is in the complication or in the side effects, mainly dry mouth, and the constipation as well as cognitive effects. Now, these are not seen or they are minimal when we are talking about the exobutanine transdermal patches and gels, which are not available in our local market. The second one, the second most common, I say, which is the sulfine azine, given in doses between 5 to 10 milligrams. It works by blocking the M3 receptor, also through liver metabolism, and the complication or the side effects when we compare it with the other anticholinergics are also dry mouth and constipation, but however to a minimal effect, and they have no effect on the cognition. Dariphenazine, the Emzalex, 7.5 to 15 milligrams daily. It's not available in our local market. Same as the sulfenazine, however, the constipation is more with the dariphenazine. Physiothyroidine, which is the Toviaz from Pfizer, given in introduced in doses between 4 to 10 milligrams, it blocks the M1 to M3 receptors. Side effects are close to those of the sulfenazine. Now, and then we come to the propivirine. Propivirine, either as immediate or extended release, we have 15 and 30 milligrams. These work by blocking M1 to M15 receptor, to M5 receptors. They could be used also in the pediatric age, and these have more constipation in compared to the other drugs, well, a similar constipation rate to oxybutynin. Tolterodine, we have two groups of them. They also have dry mouth constipation to a lesser extent, but we have a prolonged QT interval on the ECG changes, mainly with doses more than 8 milligrams per day. Finally, the trospium, 20 milligram, you know, it blocks M1 to M5. This is also have more complications with a more dry mouth than the other. So from these two slides, what we could say is that adverse events, adverse side effects are present with all of these medications. However, to a extent with some of them, mainly the sulfenazine and the physiothyroidine, in my opinion. Now, in one of the good, in my opinion, good articles, or review articles from HSO, they reviewed almost 72 articles about the combination of anticholinergics. They compared the mirapegron along with the sulfenazine versus the sulfenazine monotherapy, the mirapegron with sulfenazine versus the mirapegron monotherapy, mirapegron versus sulfenazine alone, mirapegron versus tolterodine, and the others. We'll come to talk about them in short. So, mirapegron versus sulfenazine monotherapy. What we noticed, well, what they noticed, sorry, you know, a combination showed significant improvement on all efficacy outcomes compared to sulfenazine monotherapy. However, patients still experienced urinary incontinence. So, the combination, however, was associated with higher rates of constipation, blurred vision, and tachycardia more than using the sulfenazine monotherapy. Second thing is the mirapegron versus sulfenazine versus mirapegron monotherapy. The urgency episodes were also greatly reduced than mirapegron monotherapy, and all efficacy outcomes were improved in combination therapy. However, the increased incidence of dry mouth with combination therapy was also more than the monotherapy. Rates of constipation and blurred vision were similar in the combination and the monotherapy groups. Mirapegron versus sulfenazine. Sulfenazine significantly reduced incontinence episodes more than the mirapegron. No differences was noticed in the number of patients reporting that they are now dry and treatment. Incontinence was not, there was no change. Significant higher risk of dry mouth, more sulfenazine than mirapegron, and constipation was similar in both, and there was no withdrawal rates between the two groups. Now, mirapegron versus tolterodine, the meta-analysis showed that there is no difference in any efficacy outcome between the two groups, and the higher rates of dry mouth were reported or with the anti-muscarinic and anticholinergics. However, the constipation were similar. Now, physiothyroidine versus sulfenazine and tolterodine, it has been reported that the physiothyroidine was superior to tolterodine, reducing the incontinence and urgency rates. However, there was no difference in the efficacy outcome between physiothyroidine and sulfenazine in their minimal doses, and more side effects and growth rates were reported with using physioterdine 8 milligrams. That's why most of the talks are about physioterdine 4 milligrams. Darafenacine versus trospium, similar results, no serious side events. Sulfenacine versus tolterodine, sulfenacine was better, no change and no difference in the rates of dry mouth and blurred vision. Now, in another group, in another study performed by Chapel in the European Neurology 2020, they compared the use of placebo, antimuscarinic, and the myrapigron as monotherapy. And they came with these conclusions: more adverse events when using antimuscarinics. 2, improvement was reported with all drugs when we compare it to placebo, regardless, antimuscarinic or the myrapigron. And finally, myrapigron may be a better option than antimuscarinic for those aged more than 75 years regarding constipation, but hypertension frequency was noticed to be more with myrapigron than anti-muscarinic or sulfenacine. Now, EAU guidelines on the urinary incontinence in adults, they mentioned that myrapigron is better than placebo and as efficacious as antimuscarinic for improvement of urgency urinary incontinence. Adverse events with myrapigron were similar to placebo. معناته it's safe. Patients inadequately treated with sulfenacine 5 milligrams will benefit more from the addition of myrapigron than increasing the dose of sulfenacine to 10 milligrams single tablet. Also, the guidelines on the management of non-neurogenic female lower urinary tract symptoms, the latest one, no anticholinergic drug from the EAU. No anticholinergic drug is clearly superior to another one for curing the urgency urinary incontinence. Higher doses of anticholinergics were always associated with high risk of side effects, but however, they improve the symptoms of overactive syndrome. There is no consistent evidence to show superiority of drug therapy over in of overactive bladder. معناته please try always the conservative treatment. Once daily formulations are associated with lower rates of adverse events compared to immediate release preparations. Last one or last resort, طبعا antidepressants is not our topic here, but last خلينا نقول يعني in between marks الميديكال treatment الذي هي البوتوكس مثلا، الذي تعرفوا عنه البوتوكس ولا الأونابوتولينم توكسين A. طبعا بعضهم بنقول ندخلها in the surgical side، ممكن نقول على اساس انها pharmacological، يعتمد كل واحد زي ما يحب. But it's very important to remember انه there are a number of Botox which are presented as botulinum toxin A, apobotulinum toxin A, and the incobotulinum toxin A, and these are not licensed for the use of or for the treatment of overactive bladder and urgency urinary incontinence. طبعا it has been licensed in 2013 منو الذي هو الأنابوتولينم toxin A in the form of 100 units to be injected into the bladder, and the FDA approved it also in, I believe in 2012. Now, in Untitled toxin A, in 100 units, they have to be dissolved in 10 milliliter of normal saline and then to be injected. طبعا فيها خلاف عليها, to be injected in 10 or 20 nights. برضو احنا we always refer to the injection above the trigon, لكن في من نتكلم عن الانجكشن into the trigon with single or more injections. تمام. complication rates, procedure related urinary tract infections from 2 to 20 or 32%, mild hematuria, and an increase in post-void residual urine وفي بعض الأحيان to the need of a clean intermittent catheterization. That's why هذه واحدة من أهم the most important things that had to be discussed with the patient. وكمان من واجبنا إنه we have to know that the patient will be capable of performing clean intermittent catheterization, وهذه هي temporary إلى أن ينتهي مفعول المن البوتوكس أو الأونابوتولينم توكسين، ودي احنا دائما نتكلم من 6 to 9 months. Now, the EAU mentioned that a single treatment session of Untitled toxin A injected into the bladder wall is more effective than placebo at curing and improving overactive bladder symptoms. There is no evidence that repeated injections of onabotulinum toxin A have reduced efficacy, but discontinuation rates are high. 3, there is a risk of increased post-void residual urine and UTI. The risk of bacteriuria after onabotulinum toxin A injection is high, but the clinical significance is low. And the onabotulinum toxin A is superior to anti-cholinergics in case of age of refractory Wadial comparison made at 12 weeks of initiation of the treatment. A recommendation was that offer bladder wall injections of onabotulinum toxin A to patients with overactive bladder, urgency, urinary incontinence, which is refractory to the pharmacological and conservative treatment. And we have to warn the patients of the limited duration of response, risk of urinary tract infection, and the possible prolonged need of clean intermittent catheterization. Now, minimal invasive procedures, well, minimal invasive treatments, we have the posterior tibial nerve stimulation. The posterior tibial nerve stimulation, it could be stimulated 3 ways. One way by inserting a needle, a 34 gauge needle, above the medial malleolus, and then the current will be applied. This will result in flexion of the toe, sometimes the other toes also, and the intensity of the current is determined depending on the response which you see at the time of the procedure, and the sessions would last for 30 minutes each session. The other way, طبعا أسهل, we don't need to insert anything, which is the transcutaneous stimulation, which is also available using surface electrodes. Well, last thing which has been introduced in 2017, which is the Renova iSteam, which is an implantable device, simple procedures that could be inserted over the medial malleolus, and this one will be then activated through what the patient is wearing over the or in his leg, and it could be controlled using the iPad or your telephone, depends on the software and the programs. Now, this is mainly regarding the posterior tibial nerve stimulation. The main side effects are pain at the insertion site of the needle, inflammation at the pain at the insertion site of the implantable device, and the use of PTNS and isolation in patients with overactive does seem to provide improvement. The evidence from combination studies with posterior tibial nerve stimulation and antimuscarinic demonstrates that the two together provide greater symptom improvement. Now we come to the last one, which is the sacral neuromodulation. The sacral neuromodulation, it mainly involves placing electrodes adjacent to the sacral nerve roots at S3 or S4 and delivering an electrical current to the area via an attached battery implanted in the buttock, which delivers low amplitude stimulation, resulting in the modulation of the afferent impulses التي طالعة من البلادر to the brain. وبالتالي we believe إنه it could regulate the symptoms والoveractive symptoms التي هي موجودة. However, the mechanism is still not that clear at the time being. Now, when you can see in these photos, first of all, is the insertion of the electrodes at S3 and S4. It has to be inserted there. Now, الانترستيتيوم يعني طبعا هذه من Medtronic, yes, من Medtronic. The first interstitium we used to implant 2 electrodes at S3, right and left, and then we connect them to the to this device, which you can see now. The interstitium 2 and the micro interstitium are using only, well, we are using only a single electrode being inserted into the S3, and the new types. هذا هو the interstitium 2 and the interstitium micro. These could also be implanted with safety, and we don't need to take to consider the use of MRI. من interstitium 1 دائما كان الخوف من المريض يستخدم MRI لسبب أو لآخر. This we can use the MRI من 1.5 with 30 Tesla with ease. The side effects or complications mentioned: implantation of the infection site, hematoma at the infection site, pain, lead migration, battery dysfunction of the device itself. You mentioned that sacral nerve stimulation is more effective than continuation of failed conservative treatment. Madam, the treatment failed, you don't need to continue on the drugs. The sacral nerve stimulation is not more effective than Botox or onabotulinum toxin A, 200 units at 24 months, and